Today's training is co-occurring disorders responding to substance use disorder crises. This is training that is being sponsored by the California Department of Healthcare Services. Mobile Crisis Services is designed to provide rapid response, individual assessment, and community-based stabilization to Medi-Cal beneficiaries experiencing a behavioral health crisis. The Mobile Crisis Services are designed to provide relief to beneficiaries experiencing a behavioral health crisis, including through de-escalation and stabilization techniques, reduce the immediate risk of danger and subsequent harm, and avoid unnecessary emergent department care, psychiatric inpatient hospitalizations, and law enforcement involvement. Overall, the new direction for the Mobile Crisis Services is designed to change Mobile Crisis Services so that the response is more resolution focused and really works to provide relief to people in crisis in the community. We want to support people in crisis where they are while using the least restrictive means necessary. This means that Mobile Crisis Services should be person-centered, trauma-informed, equity-driven, brief and intervention using de-escalation and resolution-focused strategies, as well as working from a lens of least restrictive interventions. We are designing the service to ensure it is culturally responsive, linguistically appropriate, and accessible to all. There are 3 presenters today, and I'm the first. My name is Jennifer Hodson. I am a principal consultant with Health Management Associates. Josh Severns will also be presenting. You'll hear from him quite a bit today. He's a subject matter expert that we're very excited about having, and he works with Kaufman and Associates. And then Ariana Mellinger, she is a peer with lived experience who also has extensive training in mobile crisis response treatment, and she will talk about her experience as well as some of the work that she's been doing. We welcome them today. Okay, so this is just the overview of our agenda. We've already done introductions and we see they're continuing to come in, so thank you. We're going to be focusing today on triaging and preparing an initial response to co-occurring disorders. We're going to assess need for medical intervention when we have somebody who's presenting with substance use and potential overdose. Overview of substance use disorders. We'll start the presentation with criteria, effects, continuum of use, some commonly used terms that describe drugs and resources for staying up to date. We'll talk about how we understand substance use disorders and co-occurring disorders together, as well as risk factors, common symptoms, treatment modalities, and we'll end with an introduction to the screening, brief intervention, and referral to treatment, of which we'll also cover the brief negotiated interview strategy and intervention strategy specifically for youth and for adults. So the learning objectives today are as follows. We are going to begin with describing at least 3 mental health and medical implications of substance use and how they may present in crisis. We'll talk about articulating trends and language used to describe highly addictive substances that are prone to misuse. Participants will learn about applying the screening, brief intervention, and referral to treatment model, and identifying stages of change and how that will help us be person-centered in our approach through motivational interviewing strategies and development of person-centered action plans. We'll also recognize and talk about recognition of the signs of opioid overdose and how to initiate an overdose reversal with naloxone. So as you know, all these trainings are anchored in the bin. And what we really want to focus on is the fact that a crisis can begin at any moment for individuals when things just start falling apart and falling out of control. And our job as Mobile Crisis Services is to really be a critical component of an effective behavioral health crisis of continuum care delivery structure. So the behavioral health crisis can refer to any event or situation associated with that disruption in order to provide safety towards resolution. What we wanted to point out with the bin is that we do have an update, and DHCS received CMS approval on July 20th of 2023. This really has been helpful to us because it allows the adding of community-based mobile crisis intervention services to California's Medicaid state plan as a specialty mental health services, drug Medi-Cal and drug Medi-Cal organized delivery system benefit. With the mobile crisis services, we're providing rapid responses, individual assessment, community-based stabilization to our Medi-Cal beneficiaries. Mobile crisis services are really designed to provide relief with techniques like de-escalation, stabilization, reducing the risk of immediate danger and harm. And while mobile crisis services are intended to support an integrated approach to both mental health and substance use related crises, our teams will be carrying, trained, and able to administer naloxone. And this is a benefit that is not intended to replace emergency medical services for medical emergencies. There may be some circumstances where teams are subject to the Federal Substance Use Disorder Confidentiality Regulation 42 CFR Part 2. So we just ask that your teams are aware of that and that they should be inquiring which teams are subject to that to ensure appropriate workflows are in place, and that we're asking beneficiaries for their consent when appropriate. And then the last thing is we want to really raise awareness to many of our community members may have intellectual developmental disabilities and other co-occurring mental health conditions that really will require us to provide services with sensory or communication adaptations. This can help us add tools to our toolbox for de-escalation of behavioral health crises. And we do have trainings coming up for that purpose, but we just want to remind you of that component when you're working on your training protocols. All right, I'm going to turn this over to Ariana. Thank you very much.
Thank you, Jennifer. Hello, everyone. Good morning. I wanted to start off with sharing parts of my story because I am a person that has a co-occurring disorder who has suffered from substance use disorder as well as living with a mental health disorder. So this was me whenever I was 21 years old. I started using substances at the age of 13 due to trauma and due to things that had happened in my life. I started off with using alcohol at first, and after progressing from alcohol, I quickly progressed to amphetamines. I started using amphetamines at the age of 14, and then I would go between the combination of amphetamines to alcohol to opioids, a little bit of the mixture. I went into rehab whenever I was 18 years old, thinking that things could change, but really it was with a push of my family that really wanted me to go to rehab at the beginning. They saw some concerning behaviors, but I had a huge family history of substance abuse. My mom was an addict growing up, and now she's a person in long-term recovery. I say those words because for me, growing up, that's what she was called. So there was a lot of stigma around that. There was a lot of stigma around me being called that as well. So I was arrested. I grew up in a very small rural community where everybody knew each other. So each time I was arrested in a crisis-like state that some stuff was going on. Each time I was arrested, I was never offered any type of mental health services until I was eventually incarcerated for a long period of time. So during this time, I was never really introduced to mental health services. I was never introduced to any type of help. My family tried for a year or two to get me help through a therapist, but it never stuck long enough because it was always my family wanting it for me and never myself until I got a little bit older. My sobriety date is actually the day I was incarcerated for a long time. So at 2017, I was incarcerated for 2 years, where after being incarcerated, I was able to become what's a certified reentry peer support specialist. At that beginning of the time, it was very new in Texas, and I was lucky that my mother was a person in long-term recovery and that she already had a great support system to be able to help guide and say, why don't you try these things? Because of the trauma I had experienced growing up, I was always knew that I wanted to help individuals, but I didn't know how because I was so dark and lost into substance abuse. So I ended up working as a recovery peer support specialist offered by the Mobile Crisis Outreach Team in Houston, Texas. It was the beginning of the light for me because I could start working in my field of choice. I've been working now since 2019 in Houston first as a peer in the Mobile Crisis Outreach Team, responding to people in at-risk placement, especially with youth and adults. I was able to get under the care of a psychiatrist and a therapist and has been under care since then. It has really helped promote my recovery for me dealing with a co-occurring disorder. I currently am now what's called a licensed chemical dependency counselor in Texas, and my future goal is to become a licensed clinical social worker. I wanted to share these things with you guys because it's such an important part of your work to realize that y'all have a direct impact in everything that y'all do. Y'all are able to really provide that hope and that recovery for that next person, even though they might not be able to see it themselves yet. So I just want y'all to really consider each person that you have that interaction with, that you have the ability to be able to help them in their recovery journey. At this time, I'm going to go ahead and pass it off to Josh.
Awesome. Thank you so much. I love hearing your story. So thank you for sharing that.
Thank you.
So we're going to jump into just overviewing the BIN and the team members for this benefit and the composition and what it might look like. So when we look at the team, we know that the first column here, the rehabilitative mental health treatment providers and SUD treatment providers, and then under the expanded SUD treatment providers, we can access services. And these sorts of teams, depending on the crisis occurring, I think are really well adept, and counties have that power to be able to say, oh, this response maybe is best served by a peer and a provider, or maybe a peer and a community health worker. So I'm not going to read through all of these lists here, as I'm sure you guys have read the BIN and been familiar with that, but really at least 2 providers in this table have to be available for the duration of the entire crisis. And it's best practice for them, not only for safety, but also you're building that clinical capacity by being able to staff in real time and then follow up care. And it's also best practice to respond with a peer because of that ability to rapidly engage rapport and build those connections on site in a scenario where they are most vulnerable. So we really want to emphasize that responding with 2 people, and if not, some counties may have some difficulties with that, but having access the entire time via telehealth to an LPHA, a licensed practitioner of healing arts, and for that clinical consultation. And I also think it's important to have peers for lived experience consultation to provide that meaningful input for the clinical people. So here's just some examples of what teams have been using for this mobile crisis benefit. This includes 2 peer support specialists and community health workers, excellent at outreach. I'm a former EMT medic firefighter, so I'm maybe a little biased there, but I think rolling with an EMT on team is an excellent medium, especially when we're looking at substance use or co-occurring crises. So talking about the steps in responding, and especially with 988 being rolled out, it's important to look at the kind of processes, and specifically with SUD crises. If it's determined that somebody is in, maybe there's risk for an overdose or a poisoning, intoxication, that's a medical emergency, and dispatch should be alerting 911 for EMS dispatch, and then the person calling should be recommended, should be told to administer naloxone. Any bystanders in the area. And also, I think it's important to just concurrently dispatch a mobile crisis team to support the continuity and the follow-up care of that person. And so if dispatch alerts a mobile crisis team to go, if they're displaying some signs that, oftentimes we're dispatched for things like mental health or, elevated behavior. And so when we get on scene, maybe it's a different story. So determining the team there, they determine whether, medical attention was needed. And so then they are the ones that contact emergency services. But if they're able to intervene without medical intervention, they can provide expert motivational interviewing, connect with a peer is the best practice, and also going into that follow-up care and getting them connected, a warm handoff, and saying, here are the meaningful treatment options available to you. And having those connections prior will really enable a mobile crisis team to make those transfers of care. And then kind of the follow-up to that is the debrief and ensuring continuity and follow-up support is provided to that person who is treated. So looking at if we are responding to, if it is an overdose, if we get there and overdose occurs over the course of 1 to 3 hours, and so it may progress as we get on scene and as we start to connect with the person. So these are some things to really look for that require immediate medical attention: irregular breathing, unconsciousness, not being able to be woken, blue tint or hands or lips, and with Black or brown people, it's going to look ashen or gray. It's going to look darker. And so just to be mindful of those sorts of things, because if a bystander is there and they don't know what to look for, somebody may pass because of an overdose. So it's important to recognize these things. And if immediate medical attention is required, then we immediately dispatch, we call emergency services. And so if we get on scene and we see altered mental status, we want to really take a look at that and decipher that and use your clinical judgment to look at, is this altered mental status due to something beyond the mental health, beyond the impact of a substance? Things like paranoia, disorientation can be, clinical, it could be medical. So that's why we want to have an assessment there for that. And again, those sorts of things may require further medical evaluation, just some things to consider. Severe headache, that's a pretty common one, but just if you're seeing other symptoms that co-occur with this, those are just things to be mindful of. Okay. So as I said, overdoses are sort of a longer period of time, but 1 to 3 hours after use is the kind of best frame of window to look at. And again, if you're dispatched for something that may be unrelated, always be mindful that there could be something going on. There could be an opioid crisis developing. And so just to be mindful of that. And the specific signs of, specifically for an opioid overdose, is slowed breathing, unusual sleepiness. If the person reports that they're calling about a friend who's not able to be woke up by being shook and shouted, you want to shake their shoulders and say their name if you know it. And if they're not responding, that's a good indicator that something's going on. And those are sort of the immediate early signs that you see. And then as you look at progressing of the overdose situation, Sometimes you'll hear gurgling sounds. You hear sort of like a choking sound, and that's respiratory distress. And it's the nervous system and the impact of those substances. So again, completely unresponsive state. And then for the late signs, we look at cap refill, which is capillary refill. And so if you just take your fingernail, you take your finger, and you notice there's pink or purple, depending on what skin you have, and you just press it for 3 seconds. It will turn a lighter color. And if that color does not return to that pink or that purple or that original color, that's a sign that your body isn't perfusing oxygen to your extremities. And that's a good sign that that's a pretty significant emergency. So definitely you want to roll with contacting emergency services. So the immediate action, if you notice this happening, it's important. Administer naloxone. It can't be stressed enough that it's best to err on the side of caution, because Narcan, naloxone is such taking it if you don't need it is not as harmful as missing out if the person really did need it. And so to administer it, put it in the left nostril first. And I say this not because there's a difference in nostrils, but because in your brain, you'll administer it in the left nostril. And then if you need to give a follow-up dose, you'll remember, oh, I did it in the left nostril, so now I need to switch to the right nostril. And so the mnemonic I use is sort of the left nostril, lay them on their left side. So after you administer naloxone, if you don't have anybody nearby, hopefully you have a partner, you have a team member that can contact EMS. And if you notice that they're not breathing, that's when you initiate rescue breathing. And again, this is just information about it. This is not constitute as a training or a robust competency building. This is just information to be aware of. So, and once they're laying on their left side, you want to kind of tuck their hand under their head so that it keeps their airway clear, so that they're not rolling over and cutting off their airway. And the desired response, if you don't see it, and that means if they're not awakening or if they have not started breathing again, that's the desired response we need. So if you notice that maybe they're still unresponsive, their capillary refill isn't coming back, they're not responding, that's a good sign that it's time to administer another dose in the other nostril and then put them back on that recovery position. So looking at intoxication, if you respond on scene and you notice intoxication, looking at things, nausea, tremors, seizures, delirium, confusion. So if you administer your mini mental status and their ANO, if they're not alert and oriented to anything, time, place, location, you kind of have to look at that and say, is that because of an intoxication? Is that because of a mental health? And that's where your rapid rapport, sort of gathering that assessment, is important. So being under the influence of substances can elevate your risk of suicide. And so it's important, if this intoxication or overdose is related to, was it intentional? Was the overdose intentional? Was it for attempting suicide? And that's when we look at things like considering a 5150. Providing water and support. Food is also, for me, food is, and so if you give me a donut, I'm happy. So sometimes that can be a really good de-escalation technique. Okay. Looking at withdrawal potentials. Again, we're sort of looking at the immediacy and assessment and management of these things, and approaching things really with a calm and open, non-judgmental, non-threatening. I'm a big person. I'm 6'4.5", 220. So I try and be aware of my posturing, and I want to be very open, and my body language just, being calm so that I'm not going to escalate that situation.
Josh, and I think you said something and really showed something really special with your hands, also being aware of your hands whenever you're approaching somebody.
Absolutely. Anything to be mindful of how you're communicating is more than just words. So providing that space and using using your nonverbals is a de-escalation technique. So some other things to consider with withdrawal and looking at issues that could arise from that. Alcohol is that's the most serious one that we look at. And that's when you see involuntary movements, muscle tremors, things like that. Delirium tremens, that's when you start getting alcohol-related seizures and things. Severe anxiety could be because of that rebound of withdrawing from alcohol. We know that alcohol metabolizes into sort of this like rocket fuel for the nervous system and the adrenaline system. So alcohol withdrawal can be fatal if it's not treated. So it's very important to assess and look at those things. Opioid withdrawal is a little different. We see muscle aches, fever, diarrhea, insomnia, things like that. And it's not life-threatening, however, it is still a pretty serious thing. So a solid intervention is to contact the county DMC access line. And so that under this new benefit, case management services are covered, so that if we're providing that continuity and support into the continuum, it's a covered resource. So just really want to emphasize that access line is available for people. And if people are going through these things and they're ready to get help and they want help, let's contact that access line and get them connected to DMC ODS or DMC.
Josh, I also wanted to say with the withdrawal, would it be also a good idea to educate family or others who are there if somebody is saying, listen, I'm using alcohol, I'm just going to quit, I'm just going to stop, and cautioning them against doing that without medical support, and then also educating family on what the signs and symptoms might be if somebody is going through withdrawal. Because I've had clients that I've worked with where the family thought they were having the flu and didn't recognize and understand. So taking that time to sort of do a little bit of education for people who may also be there when you're on call is important.
Absolutely. And addiction is a disease and it's a family disease. So if we treat and support the family, we can help bolster, the prognosis and the likelihood that person will get better. So I really appreciate that point, Jennifer. Thank you. So do we want to go into the videos? These are informational videos about the administration of naloxone and just some overall information.
I think that'd be good.
Naloxone saves lives. No time to sit idly by. More and more people are dying of overdose from the likes of heroin, fentanyl, and prescription pain medications like oxycodone and hydrocodone. These are all examples of opioids. Opioids are drugs derived from the opium poppy plant or made in the lab. They can treat pain, cough, and diarrhea. But opioids can also be addictive and even deadly. The number of opioid overdose deaths has escalated more than 400% since the turn of the century, with tens of thousands of lives now being lost every year. But many deaths can be prevented with a life-saving treatment, naloxone. When given right away, naloxone can work in minutes to reverse an overdose. Naloxone is safe, has few side effects, and some forms can be administered by friends and family. When is naloxone used? You can save a life. First, recognize signs of overdose: limp body, pale, clammy face, blue fingernails or lips, vomiting or gurgling sounds, inability to speak or be awakened, slow breathing, or heartbeat. If you see these symptoms, call 911 immediately and consider the use of naloxone if available. How is naloxone given? Home preparations include a nasal spray given to someone while they lie on their back, or a device that automatically injects medicine into the thigh. Sometimes more than one dose is needed. The person's breathing also needs to be monitored. If the person stops breathing, consider rescue breaths and CPR if you are trained until first responders arrive. How does naloxone work? Naloxone is an opioid antagonist, which means that it blocks opioid receptors from being activated. It is so strongly attracted to the receptors that it knocks other opioids off. When opioids are sitting on their receptors, they change the activity of the cell. Opioid receptors are found on nerve cells all around the body. In the brain, opioids produce feelings of comfort and sleepiness. In the brainstem, opioids relax breathing and reduce cough. In the spinal cord and peripheral nerves, opioids slow down pain signals. In the gastrointestinal tract, opioids are constipating. These opioid actions can be helpful. The body actually produces its own opioids called endorphins, which help calm the body in times of stress. Endorphins help produce the runner's high that helps marathon runners get through grueling races. But opioid drugs, like prescription pain medications or heroin, have much stronger opioid effects, and they're more dangerous. Over time, frequent opioid use makes the body dependent on the drugs. When the opioids are taken away, the body reacts with withdrawal symptoms such as headache, racing heart, soaking sweats, vomiting, diarrhea, and tremors. For many, the symptoms feel unbearable. With continued use, opioid receptors also become less responsive, and the body develops tolerance to the drugs. More drugs are needed to produce the same effects, which makes overdose more likely. Overdose is dangerous, especially for its effect in the brainstem, relaxing breathing. Breathing can be relaxed so much that it stops, leading to death. Naloxone knocks opioids off their receptors all around the body. In the brainstem, naloxone can restore the drive to breathe and save a life. But even if naloxone is successful, opioids are still floating around, so expert medical care should be sought as soon as possible. Naloxone works for 30 to 90 minutes before the opioids return to their receptors. Naloxone may promote withdrawal because it knocks opioids off their receptors so quickly. But otherwise, naloxone is safe and unlikely to produce side effects. Naloxone saves lives. From 1996 to 2014, at least 26,500 opioid overdoses in the United States were reversed by laypersons using naloxone. While naloxone is a potentially life-saving treatment, more needs to be done to solve the opioid overdose epidemic. The National Institutes of Health launched the HEAL initiative in 2018, expanding research across multiple NIH institutes and centers to speed scientific solutions to the national opioid crisis. Research is underway to improve treatments for opioid misuse and addiction, and to enhance pain management. The National Institute on Drug Abuse, or NIDA, is a leading NIH institute for research on opioid misuse and addiction, and its support helped the development of the user-friendly naloxone nasal spray. For more information, see NIDA's website at drugabuse.gov and search naloxone, or visit nih.gov and search NIH HEAL Initiative. General opioid information can also be found at medlineplus.gov. This video is produced by Medline Plus, a trusted source of health information from the National Library of Medicine.
What's your emergency?
That's a great video. And I also, that the amount of administrations of naloxone up until 2014, and then we didn't start seeing too much fentanyl, and now we're seeing a lot of isotonitazine. So the amount of administrations of Narcan and the accessibility, I'm sure that number is significantly more now. And ISO, I've seen a question about ISO, and I think also that is another opioid emergency and opioid crisis. So responding the same way, best practice is to use Narcan, use naloxone, and with kind of the gravity and the significance, the potency of these substances, we're going to need maybe a couple doses. So especially, I was going to talk about xylazine and being mixed with fentanyl, and Narcan does not work on xylazine, but what xylazine is doing is it's giving fentanyl legs. It's letting it really creep because it's synergistic. It works really to slow down the breathing. And if somebody is using fentanyl or other opioids and it's mixed with xylazine, there's a good chance when you administer Narcan, they're not going to become alert. They're going to just maybe start breathing again. And so it's important to be aware of these things, and it heightens the risk for overdose, of course, and also other issues that may be present with these cardiac issues and respiratory issues. And a sign to look for are necrotic skin lesions, so black track marks and things like that on the surface of the skin, and the antecubital areas and other areas where injection might be happening. So just some things to look for. Talking about the Good Samaritan laws and the protections. Now, this is as responders, it's important to know that you are trained and you're protected, and also you want to make sure you get adequate training. So this is just information about administering naloxone and kind of the use of it and the potentials for it. So these are legal protections that protect not only people prescribing naloxone, but also we want to share this information with the people and the families we're responding to, that they're protected if they are under the influence of substances, or if they have possession of substances and they call for help, that they're not going to get in trouble. They are protected legally from that. So California recognizes this, and it is codified in the health code. So best practice for following up is debriefing with a medical team, getting that check-in within 72 hours. Of course, documenting the incident. And if you are encountering something like this during mobile crisis response, you are likely going to be connecting with other services and systems, acute detox centers. And so that wraparound care and that case management as part of your aftercare, your follow-up check-in, it's important to document all those things in your notes. Who I spoke with at this hospital and transfer of care was happening here. It's important to document everything there. So it's in the bin to provide this check-in within 72 hours. And this can be telehealth, but if you're able to in person, it's great. So just throwing that out there as best practice. Okay. So since we have a lot of experts and familiarity here, I'm not going to go too much into this, but the criteria for meeting substance use disorder is there are 11 symptoms in the DSM-5 text revision, and we have to meet 2 for within a 12-month window. And so these are the symptoms associated with that. And we really look at how does it affect their functional domains? How does it affect their school, work, social life? And here we look at substance use on a continuum. So not everybody is going to meet criteria for a mental health disorder. They may display symptoms of it. Not everybody is going to meet criteria for a substance use disorder. In fact, I think the majority of the population in America uses substances or drinks alcohol responsibly. And so there's non-use, where it might be a conscious decision to abstain because of personal or cultural reasons. And then going along the continuum, looking at experimental use and going into recreational use, it's happening maybe more frequently. And when it starts to become a problem, you start maybe they notice the way it's affecting their family, it's affecting their job. Maybe they're hungover, they call in late to work, and then it sort of goes from there. And then it builds up to physiological dependency. And this is from the Samsha Espert models of care. So that's why we're going to talk a little bit about that later in this talk. But when we look at problem and risky use and then physiologically dependent use, that's where that RT, the referral to treatment, happens. And then the experimental use up until the regular use, that's where we look at brief intervention or education. Or if there's not problems, then we just sort of reinforce positive behaviors. So again, to meet criteria and the severity of it is if they have 2 to 3 symptoms. 2 is the minimum. If there's 4 or 5, that's the moderate level SUD. And there are specifiers on your diagnoses, on your F codes. And then severe, of course, is having 6 or more.
So I just want to kind of look at, so why do people take substances? So if you look at the quote, no single factor determines whether a person will become addicted to drugs. People, they can experiment sometimes with youth. They can be in social settings where other people are experimenting and they decide to as well. There can be cultural and social influences as far as they're going, and maybe families are using as well. So they see their parents might be using. Some of those things can be really hard because if the parent doesn't see it as a problem, and as Josh was talking about, they kind of start to see their youth into progressing into that kind of more riskier usage, and they think that the youth should stop. Well, the parent might say, my usage is not a problem, it's the youth. So really educating families into learning how to really help the youth as well can be a huge thing. Some people also take substances in order to cope with emotional or physical pain. And whenever you start to see people come off of opioids, a lot of the times they'll talk about that physical pain that they're experiencing. And so it's important to listen to those things as you have the interactions with the families. Terms to describe drugs. So as we're interacting with people and as you're going out on calls, it's important to understand that not a single person is gonna have the same jargon. They're not gonna have the same words to be able to hear it. So really coming at it from a point of curiosity, coming at it from a point of understanding what substances they're consuming, understanding why they call it a certain thing. So you really want to be able to listen to that language, because sometimes what they're describing isn't always going to be what you might think it's going to be. So you ask the person to teach you what the certain substance is. You'll say, you stated that you've taken TNT. Could you please tell me what that is? Could you tell me what it looks like? I heard you say that you have the shakes. What do you think is causing that? So the person that you're serving is going to be the individual and the expert in their life. They're going to have an idea about what's going on inside of their body. And so just really coming at it from a place of curiosity is the best understanding to be able to really give them the best support there. So these are some street names that we found that you might hear while out in the field. You might hear whenever you're coming through an assessment and say, oh gosh, well, what does that mean? So some of those things you might hear in Adderall, you could hear as somebody describe it as an Addy. You could hear a person describe cocaine as something like white lady or yayo. So things like that, whenever you hear it in the assessment, you stop and you say, oh, hold on, could you tell me what that is, or what you're consuming? What color is it? What does it look like? What effects does it have on you? So I really want to show you that the different words for fentanyl. So there are people who are choosing to use fentanyl as their primary substance of choice. So whenever you're listening for those words, you can hear them say, maybe sometimes they might describe it as China white, or they might describe it as something like blue diamond. So again, really coming at it from curiosity to understand what that substance is.
And that's a great example of just a list that enables you to keep your ears open and to be able to understand. It's not to like be cool and to have the lingo. It's really just to be aware and just to keep your ears open for that. And so when we look at co-occurring disorders, it's the presence of a diagnostic criteria threshold being met for both a substance use disorder and a mental health disorder. And we know that substance use disorder is a chronic pattern that harms them, that harms their domains, their life, their health. And we may look at it like, we may delineate it as, are they self-medicating because of a mental health symptom? Or is a mental health symptom the contributing factor there? Are they self-medicating that? Or do they have the mental health symptom because of the impact of substance use? And so really looking at kind of the duality there and understanding that really it looks at history and getting a contextual understanding. But in crisis response, we have a very brief window. So understanding that in crisis, somebody may have turned to substances and it may be looking like that. So turn it over to Ariana.
So I do want to do an activation warning here. Some of the content that we have might just be bring up some stuff, especially since you guys do work in the field. I want y'all to take care of yourselves to the best of your ability. And if you need to take a break, please take a break. So we're going to go ahead and go into the adult case study. So referral was made to Mobile Crisis Outreach Team through a collaboration with a VA. It was a woman who was 45 years old who was having a crisis due to her living conditions. She didn't have access to her medication at the time because she needed to be re-rated through the VA. She had a diagnosis of bipolar type 2, and she was using alcohol, cocaine, and Vicodin that she was obtaining through the street. Whenever we arrived there was no running water, there was no electricity, and she had reached out to be able to get help through services. So she accepted the services once we got there, and we noticed just everything that was in disarray. We recommended maybe potentially saying, hey, well, we see that you have this usage, and would you be willing to get help for the substance use? She accepted it, and she was willing to go and stay at a sober living home. During the time she was at the sober living home, she was able to connect with an AA group, and she was able to maintain long-term sobriety for herself and what that looked like for her. During that time, through case management services, she was able to get back on her feet. She was able to help get utilities back in her home. And eventually, through applying through disability with the VA, she was able to get her house out of foreclosure. She had her house in foreclosure, and everything was in disarray because she had lost her nursing license at that time. Through going back and getting her life in recovery, she connected with the Mobile Crisis Outreach Team just to check in and say like, hey, things are going good and I now am in my house again. To get to hear that she's living the life that she wants to and to be making progress on her co-occurring disorder was amazing. She is now able to live the life that she wants, and she was able to get her nursing license back. So what are some common co-occurring mental disorders with substance use? I'm going to go ahead and pass this one on to Jennifer.
Sure. So as many of you know, oftentimes people who are using substances have also experienced things in their lives and may have had prior trauma, may have experienced depression, anxiety, treated, untreated. youth and adults, any age. So it is really important when we're working with people that we honor that substance use is a lot more complicated than it alone. It oftentimes comes with other co-occurring mental disorders. In fact, I was looking at this report published by SAMHSA in 2022, and I put the picture of it on the slide and the link to it because I think it's a real fund of knowledge, and it talks quite a bit about some comorbidities and co-occurring disorders that would be really important for people to be aware of for their work in mobile crisis. But the alarming statistic that about 45.8% or 15.3 million people between the ages of 18 and 25 have either a substance use disorder or any mental illness. So as we're walking into these homes, meeting people where they're at, we are oftentimes needing to be painfully aware that this is a solution that people are using instead of the problem. Now, there is some research that we know as clinicians, and the DSM-5 has lots and lots of comorbidities that it'll link to different substances, but it also will say that some of our mental illnesses put us at risk for developing substance use as well. So if we're having sleep issues, we might be using substances to help mitigate that, which could then lead to other problems down the road. Or we see conduct disorder is oftentimes a precursor to substance use disorder, or again, untreated ADHD, depression, mood disorders, anxiety. So that's why it's really important with early intervention, getting people the right services at the right point in time, as some of these, oh yes, grief is a strong trigger too, absolutely, Joy. People who have been through normative, painful life events, unrecognized, unprocessed, untreated, and some families struggle. We struggle with opening up to our pain. We struggle with acknowledging the need for help and support. So there's a lot of stigma in reaching out for help, and that the solutions that we tend to gravitate toward can put us in even greater harm. So being able to really recognize it's a both and as we're working with people out in the field.
So in order to get the care, and especially when we're looking at co-occurring disorders, crisis teams are often like the first point of contact for those who are in help or in need of help. And so being informed about knowing the difference between DMC ODS and DMC standard programming, and with the experience and expertise here, I'm sure this is sort of redundant, but knowing that there is a county access line that can connect the person if your county's opted in to ODS, and recognizing that that's a resource for you. It allows for a seamless handoff and connection, and you can support that person in crisis in that phone call. And then once again, documenting that for follow-up and just for your follow-up to make sure that person made it, or if there's any support you can offer for them as they go along that care continuum. The DMC ODS was a Medicaid waiver that was signed back in 2015, and it was modeled after the ASAM levels of care and the framework that ASAM uses. And so it's really, really great how they integrate the access and how somebody can get involved in that care continuum. And so with the expanded ODS program, case management's covered, recovery services, MAT more than just methadone, so Suboxone, those sorts of things are covered. And so it's really important to get kind of the integrated care. We'll talk about models of care in a little bit, and how getting that person connected to that county access line is really important. And in the ASAM criteria, there are specifiers for co-occurring, enhanced, co-occurring capable, and that can be sorted out when they do their assessment. But one thing that can be offered in field is the initial screening can be done. There's a bin that speaks to this, and the initial screening was created by our friends at UCLA ISAP. It's the bin 21-071. It talks about that abbreviated ASAM tool. So I put a link here for the brief questionnaire for initial placement. That can be given in field, and it's really brief, couple questions. It's an online kind of standalone access, And I'm sure with some handy IT people that make the world spin, they can get that integrated into your EHR. And it also kind of helps you identify those people that you're referring to, those care organizations. And it really empowers mobile crisis, because this benefit is really expanding and innovative. And so being able to support that person in SUD crisis, on the spot to get the ball rolling, because that window of time for change is sometimes very brief. So if we're there and we're able to support them, I think, it's great. Okay, so moving into some of the medical issues that we see going on, the medical consequences related to substance use, specifically from like the routes of use and directly how these things are sort of impacting people. One of the bigger ones we see are liver diseases and prolonged substance use and exposure to the body. There's studies that show how the liver is just sort of in constant repair mode. It's in crisis mode when there's prolonged substance exposure. And so we can see things like jaundice, which is a dysfunction of the liver. But once it's reached that point, there's some really underlying things that we need to look at. And the risk of hepatitis C and HIV from sharing materials, also another thing to be mindful of. And I bring up these medical things because this is part of integrated and co-occurring care, is because we treat the whole person, not just the SUD symptoms, not just the mental health. We also want to look at the Dimension 2 aspects, which are medical. Wernicke's-Korsakoff syndrome is something that in my experience, and the research reflects this, it is very underdiagnosed. And what that is prolonged alcohol use can cause nutrient deficiencies in the brain. And so the symptoms of Wernicke-Korsakoff is they appear as though they're intoxicated, really stumbling around, can't find their balance, kind of like amnesia type disorientation. And it is very easily treated. And a lot of the times we see that symptom and we just pass it off as, oh, that person's intoxicated. And while there may be something underlying that. And so that also stresses the importance of just looking beyond what you see and getting deeper into that to support the person. Also recognizing that diabetes, to be mindful of other medical things to consider and how it affects somebody in crisis. So knowing the adolescent brain is very malleable and it's sensitive. And so understanding that if we are responding to a crisis and there's an adolescent, really there's heightened risk of that. And the substance use early on sort of is an indicator of lifelong usage and a higher likelihood of developing a SUD later in life, the earlier that those substances are kind of happening. So, and it does this by changing the reward system of the brain. And I'll talk a little bit about the disease model here in a second, but it's important to recognize that. And the SBI part of SBIRT is providing that brief intervention, that education, and like Jennifer was saying, that family support.
We have another case study to look at. So this one is specifically within a youth. A youth was referred to us through 988, and a peer and a clinician was able to respond. She was 15 years old and she had had an argument with her mother. She was feeling worthless and having lots of thoughts of self-harm. So she had experienced a suicide attempt the year before after being sexually assaulted. After all of this occurred, she started smoking weed to feel better as a means of escape. She reported to us that she wanted just the bad feelings to go away and feel normal again. Her mother was unaware of the sexual assault until the mobile crisis outreach team was able to provide the services. Through the assessment, those things had came out. The mobile crisis outreach team provided resources and a warm handoff to a community-based organization teen substance use disorders that specialize for her to be able to get help. Through the education and during follow-up consultation, we'd be able to have received the services and get an urgent appointment with the CBO. We were able to debrief the call and document all of the outcome. The referral and the follow-up was able to be made, and all for the youth to be able to receive services. I find it important to look at the youth studies and the family studies and the adult studies throughout the time as we go through our presentation to really put a face with whom we're servicing and how these can be effective in your services today. I'm going to go ahead and pass it back off to Josh.
So like I was saying, the disease model of addiction, we know that there's genetic predisposition. There were studies done about twins growing up in separate environments, and the appearance of disease in both of them, in both those twins. There are certain genetic markers, the DRD2, A1 allele. It's just kind of shows that there are specific genes that kind of correlate to that. And we also know that adverse childhood experiences, or ACE scores, are correlated with higher likelihood of developing SUD. And psychological factors, stress. Somebody mentioned grief. That's a great point. A lot of times there's no hope, and that coping is there. And one of the hard things about substances is it's a very effective substance because it changes our physiology and our feeling and our emotional responses. We need to feel something, and so a lot of people turn to that. So and there are also cultural, societal factors. I know as a former firefighter, medic, it is a culture in the first response line, and we see that a lot because of that, continuous kind of crisis exposure. So just some things to be mindful of. A clinical indication for, further assessment for co-occurring is multiple hospitalizations, and seeing somebody's sort of the recidivism there is a good indicator that maybe something's not being addressed. And maybe they say, I haven't had any luck with this type of therapy, and that really hasn't worked for me. And maybe maybe there's a good reason why. There's an underlying co-occurring disorder. I'll give it over to Jennifer for this section.
Sounds great. Thank you, Josh. And thank you, Ron, for doing such an amazing job. Your knowledge is it's inspiring. So SBIRT, years ago, we were made aware of SBIRT. Primarily, I learned about it first working in primary care settings. And what we're seeing is the expansion of this evidence-based approach, allowing us to really focus in and provide comprehensive care services to people in a variety of settings. So these SBIRT's been used with people who are at risk for developing mental health, substance abuse disorders. It could be used by people who don't even specialize in substance abuse treatment. You can teach it to family members as a way to have a conversation with people regarding use or symptoms that they might be experiencing, because it's person-centered. And it can be offered in any public health, medical related setting, like a mobile crisis response. So SBIRT really does allow us to deliver that person-centered care that the BIN is really wanting us to be able to deliver, where we're being most responsive to the needs of people as they see it. The outcomes that are being measured and observed in research is SBIRT's got some pretty good outcomes. It can, stem progression to severe problems, which means we can, keep it from moving into something more severe. It can improve medical conditions that are exacerbated by behavioral health issues. So when we're able to meet people where they're at, get them right-sized care for where they want to go next, we might be able to see some additional changes. I had somebody I was working with once and used SBIRT because, she was a caregiver in her family. And oftentimes, a lot of the people that we're seeing carry the heaviest loads are carrying loads for others as well. And so she had diabetes, she had hypertension, she was working on some weight reduction, and her providers were really, really struggling to try to figure out how to get her to really begin to focus in on herself. Well, through setting some goals and some work around some of the things that were most important to her. Her heaviest burdens were not necessarily her own health conditions. It was some of the depression she was carrying, as well as the support she was giving to her grandchildren. Once we were able to deliver right-sized care, we saw these medical issues improve. It also can use as a preventative from medical conditions, reducing substance use-related infections and infectious diseases. You may have attended the training on harm reduction. So there's lots of things we can use with SBIRT in the field that helps provide education for people to reduce more serious consequences of use. It also can be used for those at higher risk of misusing prescription drugs, and we see a lot of research showing it has a positive influence on social functioning. So substance use can really, and co-occurring disorders can really minimize our social circles, and this can probably bring more positive light and hope to people by expanding through person-centered support. The great thing about SBIRT has also been studied with adolescents. So nationwide, we know that 30% of high school students reportedly have used alcohol in the previous month, 14 illicit drug use. 5 substance groups accounted for 96% of the primary substances reported. And these are alcohol, opiates, marijuana, stimulants, and cocaine. So these are the ones we're seeing aged 12 and older. So young people. And then 43% of adolescent treatment admissions were referred to treatment by the court and the criminal justice system. So really with our mobile crisis services wanting to get to people before they're experiencing law enforcement or the justice system. So this is something, and with SBIRT, it's really difficult to know at times if a child is evidencing signs of substance use or behavioral health symptoms because they share so many comorbidities. Teenagers can be moody, teenagers can sleep a lot, teenagers cannot sleep a lot. So it really takes everybody looking in and being present with these adolescents to be able to deliver right-sized care. Some co-occurring mental health and substance use issues in youth. Oftentimes youth are using substances, and Ariana talked about this previously as well, to cope with behavioral health symptoms. It could be they've been through some things, some trauma that they haven't shared with anybody else, and that is a gateway into using for relief. We do know that stopping substance use can result in an increase in behavioral health symptoms. So somebody who may have been using for relief, who's no longer, can then experience all these really big, powerful feelings, memories, thoughts that they need that support with. A lot of times our youth really believe some of the marketing and the information that they've been given by not so reliable sources, that they're safe, they're natural. And then they really hold on to this idea that substance is the only thing that works for me. Weed is the only thing that works for me. So we really have to work on, again, with the SBIRT approach, we can deliver person-centered support, information, and education, but it's really following their lead. There's a link to a video that shows why and how it is so important to pay attention to co-occurring disorders among our youth. I wanted to bring this up too, because in California, Code 6929, so this is minor consent to services. So in the state of California, minors 12 and older, they can consent to medical care and counseling in the treatment of drug or alcohol related problems. The only limitation caveat to this is they cannot consent without parent or guardian consent to receive replacement narcotic abuse treatment. So because of that, we want to walk into our work being family-centered, but we do need to ask the teens, the youth, for permission to include parents or others. This might be just to pull them aside and just encouraging them to take the lead in sharing. That way they have a little more control about what's being said to their parents and their support system. This can involve helping the parents using things like reflective listening skills. So what are we, not only are we modeling these skills when we go into the field and showing others how they can interact with the adolescents, but we can also teach them at the same time on how to use these skills to further engage their youth in these conversations. We can guide teens and parents then on how to develop an action plan. So hopefully the idea is bringing them both together and what they can do to share support in that action plan. And then really connecting with our youth and the parents about family or other experiences that they may have had with a substance use disorder or co-occurring disorders that may have impacted what perspective they're taking on their own action plan. So some core elements of SBIRT, there are really 4 main components. The first one is screening. So this is very brief screening that's used to identify behavioral health issues. It's oftentimes completed, depending on your dispatch, before or during a mobile crisis team response. Then the team will move into brief intervention. By standards, they say 5 to 8 minutes, where you're really working to raise awareness using things like motivational interviewing, which will be offered more at a future training, and really helping motivating people in the field to acknowledge and address their problems, the problem that they're experiencing. Some of your teams may be able to offer more extensive treatment, like CBT strategies for people who are evidencing higher risk. That might mean SBIRT might take just a little bit longer. So they're saying about up to 30 minutes. And then referral is the last part of the SBIRT, and where we're really looking at what would be the next step that this person wants to take towards addressing their behavioral health substance abuse needs. Again, the main goals of SBIRT are we want to increase access to care. So for people, that we're working with, it's trying to see what barriers can we help to remove so that they can take advantage of services that they do or feel ready to receive. Sometimes it's planting a seed. So access to care might be, if down the road you decide you do want to do something, what would be some barriers that you might encounter? And here are some resources that you might be able to use to prevent that from being a barrier. Some of the goals also is to look at a continuum of care. So we may integrate a variety of medical services like primary care and behavioral health services so that we can provide a range of options for people so that it doesn't have to be choosing one or the other. And then again, proving those linkages between services. So a lot of the support that we have for people oftentimes occurs in siloed systems. So SBIRT is really trying through its approaches to get people to work together on coordinated treatment plans and collaborate so that people who are experiencing crises feel supported and not that they have to choose. There is a screening process that is evidence-based. At the bottom of the slide deck, we have included visual images of the pre-screens of the screening tools. The pre-screen is really designed for people age 18 and older. You have a question on alcohol screen, drug screen, and then there's a couple of questions for mood. So it's kind of getting more toward looking at, is it the person who's also struggling with depression? You can come up with a pre-screen too for adolescents. That can also be an option as a way into having a conversation about use. The alcohol screening is a little bit more detailed. It has actual images. So what constitutes a drink, the size. And so you can understand more of what people are describing to you as far as their use goes. Same with the drug abuse screen test. Now, please know that some of these, particularly the DAST-10, it does have a permission for use, but it just is something that you can do online. So when we're working with people, it's important to introduce the screen, let them know what the questions are designed to do. So these questions are going to be able to help us provide you with the best support and services possible, that we're not doing this to judge them. We're not doing this to label them. We just want to do this to best support them so that we're making sure we're giving the best resources for them at the time. There's a link too on this slide that can take you to a page where they're offered in multiple languages, which is really critical when we're providing culturally responsive care, that we're also prepared to be able to pull up a screening tool where they can read, or it can be used to deliver to somebody in the language that they prefer. When we're working with people as well, we're looking at the stages of change. Now, Prochaska and DiClemente developed these stages a while ago, but they're still very, very important, because what they do is help us understand if somebody is pre-contemplative. That means they're not yet ready to stop their use. They're not ready to take any steps toward treatment or services. So the kind of conversation we have is going to be at that place with people. It's like, okay, well, right now it sounds like you're saying you're not interested in doing anything different. Can you tell me a little bit more about that? Or if you were to make a change, what would be the first change you would make, and how would you know that's the right time? So using some questions, some open-ended questions to really help understand where the person's at, and then how do we help them to decide they're ready to move to the next step. And again, they decide, they choose. Contemplation might be they're starting to think about changes, and many of you, since you're so experienced, you know all these stages. Preparation is they're starting to do things to prepare, maybe somebody who can help with the kids, ways that they're going to be able to cover their expenses. I mean, there's some practical things that a lot of our families and individuals need to figure out before they take action on getting services. And then the action stage is they're ready to receive services, treatment, attend that first meeting, walk in the door, which is a big, brave step to get services. Maintenance is continuing to participate in treatment, and then knowing that relapse can happen at any point in time through that process. And how do we then reconnect with getting them back into a place where they're ready to begin participating in that process again?
So I think that is really an important part of whenever you can include a peer support specialist, actually, is whenever you can include that lived experience alongside the clinicians' ideas and how they understand the model, and then really implement it for the individual that y'all are serving.
Absolutely. Thank you. Thank you so much for that. And that's why our teams, as we shared at the beginning, can be very diverse in structure, because having that balance of experience, that balance of relatability can make the difference between somebody deciding to do something different and somebody not feeling like the person delivering services can connect with them. So it's a huge benefit that we have. Thank you very much. Okay, so there's a 4-step brief negotiated interview. I'll walk you through this fairly quickly, but there are resources provided where you can get back into this with greater detail. The reason why brief negotiated interviewing is really functional in a mobile crisis response is because it can be completed in 5 to 15 minutes, whereas motivational interviewing can take up to 20 to 30 minutes if you're really going through the steps as they've been outlined. But they are really important resources. Both are teaching us a style of communication. So it's not so much an intervention, but a style of communication where we can initiate change language that helps the person that we're working with to set and reach a specific goal. So it really is about meeting people where they're at and the person's own reasons for change, and really leading with acceptance and compassion as those of us that are working with people in the field. And again, the people that are around them also there when you're providing this support are watching this and learning from it as well. So whereas people may have been yelling at them, getting them to stop using, restricting them, isolating them, watching you come in with warmth, with your lived experience, with accepting and compassion, and watching how that changes the conversation is going to help the whole family be able to do that as well. The steps are building rapport, providing feedback, building readiness to change, and then negotiating a plan for change. So we'll take you briefly through each of these steps. The first important part about building rapport is getting consent. So as you're moving through this, if somebody says they don't want to talk to you about their alcohol use, they don't want to talk to you about the drug use, no means no. So we'd rather work with them on what they're willing to talk about. So if that particular day they're upset with how their parent responded to them with not being able to go out with friends, and that led to a crisis event, and that's why you're there, we work with that. We try to then move towards some language that can support them if they're ever, wanting to do something different, and then support the parents in the signs like Josh did so beautifully earlier. What are the signs of use, withdraw, dependence, so that people can get care urgently if needed. We do start with general conversation, open-ended questions. So, all of those are just things that don't end in yes, no. Now, there is a time for yes, no questions when we're doing assessment, but at this stage, we really want some open-ended questions. It gives us a way to use the language that they're using, the descriptions that they're using, and it shows them that we care about what they have to say. So questions can be, tell me about a typical day. Where does your use of marijuana fit in? So are you using first thing in the morning, during the day, at night to go to sleep? So we understand, a little bit more about maybe what is it a solution to help them with something that they're struggling with? And this can help us with the referral and the plan. We ask about what are some good things about using. Remember, we talked earlier that oftentimes people get into use because they're trying to solve a problem. So what are some things that it's helping them with? And then what are some not so good things about using? Throughout this time, we're using reflective listening, repeating back what we hear. Sometimes we might need to stop them after a little bit to say, you've shared so much with me, and I just want to make sure I'm getting this right. And you repeat back what you're hearing to confirm. It also helps slow down the conversation a little bit. So it's a little bit of a de-escalation strategy. Make sure that we're listening correctly, lets them know that they're being listened to. And then it also sometimes helps them move on to something else, because people tend to repeat themselves when they're not sure they're being listened to. The second step is to provide feedback. So we ask permission. I have some information on cocaine use. Would you mind if I shared it with you? We don't ever want to assume that people know and understand what they're using, how harmful it is, what it does to the body, connecting some of the dots on the fact that they're having a lot of GI issues and alcohol use. So if we can provide some handouts, and you might find as you do this work more and more, you get a collection of materials that are your go-to materials, and you might share them amongst each other on your mobile crisis service teams. But it's helpful to have them in multiple languages. It's also more important to ask for permission before you give them. We also want to discuss screening findings. So remember those screenings we did at the beginning. So maybe connecting back to those and saying, remember earlier when I asked you these questions? So here's some things we know about use and what you described and how you're using and what it can put you at risk for. So we use their own the responses of their use to help educate them where they're at. And then look for a response. So if it's a curious response, a positive reaction to maybe moving forward to a stage of change where they're action oriented, then great. If we see non-verbally or verbally, they're putting the brakes on, and we see that sort of a response, then what the evidence-based approach says is let's go back to the pros and cons of use. So maybe we're not understanding enough about the benefits of the use to be able to then have a discussion about the cons of use or moving them to some sort of response strategy. So we might find ourselves going back to that. Now, sometimes that's where you end as pros and cons. Sometimes that's as far as we can get, but that's a lot. That is a lot, because most of the conversations they may have had before that were very different. So we're really moving down a path. If we can get to pro and con questioning, and that's as far as we get, you've done a lot. The third step is building readiness to change. Some of you may have heard about the readiness ruler. So we call these scaling questions in solution-focused therapy, but we set up a scale of 1 to 10. Let them know what the 1 is and what a 10 is. So if we want to say it's important, how important is it for you to change your use? If 10 is the most important, 1 is the least. Where would you say you're at right now? How confident would you be, that you can change that? You can move that to a higher number. And how ready are you to do that? And if they give us a number like the 2 is circled on the slide, I'm curious, you said it's a 2 and not a 1. Why didn't you give it a lower number? What's going on for you that you think you might be just a little bit ready? And then what would it take to raise that number? Sometimes I'll even go halfsies, even to a 2.5. What would get us a little bit further up to being ready to do something different or important, knowing that it's important to change. So we can even get them going just a half. So that's the readiness ruler can be a really helpful way to be person-centered, led by them as far as where they see their uses at, where they see their readiness to changes, even though you may have greater concerns or the people around them might have greater concerns. It's working from where they're at. And then the fourth step is to negotiate a plan. So first thing is to emphasize strengths. So what are some of the options that will work for you to stay healthy? What will help you to reduce the things that you don't like about using or the way that you're feeling? So looking for what are some coping strategies, some strengths that exist in their current system, people that they may have to support them, access to resources, like they may have a smartphone where they can download an app, or they may have the capacity to participate in telehealth, or they may, have a friend who's also trying, to quit. So really looking at strengths, identifying supports, who around them, what around them. It might even be, an animal, that this animal is supporting them and is there for them. And so we're gonna build on anything we can to show this individual who may think that nobody cares, the things that are around them that can help lift them up as they're trying to move toward a place of health. Write down steps, as they're talking, I could do this or maybe this. We're going to write that down. Okay, let me write this down. You're coming up with some really great ideas I didn't even think of. I'm going to write these down so we can revisit them and summarize this before we go. And then offer resources that fit their steps. I oftentimes like to say, I have some additional resources that some people find helpful. Would you be interested? Things from smoking cessation. We know there's a lot of strategies that can help. Do you think you're ready to maybe learn about some of them today? That sort of helps with some of the resistance that we might get by just saying, we think you should do this, allows us to be person-centered and move from their curiosity. And at the very end is thanking the person in crisis and the support persons present for your being there today. When it comes to referral, so this is a resource that I wanted to show you. There's county level referral resources. These are all hyperlinked, so you can look and see what's available in your areas. There are differences, obviously, in an urban area, like is shown on the screen, where Los Angeles has, got lots of different types of facilities, to more rural settings where there may not be. So we want to make sure that as you're going out into the field, you're aware of what is accessible to people, as well as telehealth opportunities for people. There are national resource databases. So we want to make sure you are, prepared and you have things available at your fingertips so that you can look things up should you encounter somebody who's ready to make a change. And then, of course, you'll always have consultants and other supports, and we'll show you that as well to help you. Now, somebody said earlier in a question, we may not have an option other than to offer sequential treatment because of policies in the community. And certainly sequential treatment is an option, although through research we see it's really the least ideal because if we don't treat psychiatric mental health symptoms, it can interfere with addiction treatment and vice versa. Parallel treatment means you're both happening at the same time, but in separate facilities. And as you can imagine, that can also be a challenge. And then the ideal, what we're seeing is the gold standard is more integrated treatment. So being able to find facilities and treatment strategies that are both and. We also mentioned this in a prior treatment, but to remember your crisis counselors have access to free service, this California Substance Use Line 24/7, where you can get clinician to clinician support. At the end of the presentation, my colleagues had come up with a whole list of resources for AA, NA, Al-Anon, and NAMI, so that they're all linked so you can see about resources in your community that you can refer people to, again, meeting them where they're at. And then also in the county level, you're going to want to compile a list of on-demand accessible resources. So do you have on-demand psychiatry resources, primary care provider resources, licensed practitioner resources? And if not, when are they most accessible? Are there walk-in services available in your county? So this is going to be really important to have as you prepare to move out into your field, into your service area. All right, so in summary, we just want to thank you again for your participation. We're going to do a little bit of Q&A, but just want to cover the main parts that we went over today. We know that substance use is associated with an increased risk of developing one or more co-occurring mental illnesses, depression, anxiety, sleep, additional substance use disorders, and many, many more. So not treating one and treating the other is incompletely caring. So we have to really think about how do we coordinate care and move in unison. Some mental illnesses like generalized anxiety, depression, bipolar disorder, schizophrenia, ADHD, conduct disorders, again, they can be risk factors for developing as people are going to look to try to find relief. So that can actually lead them into developing a substance use disorder as a result. It's important that we genuinely ask, and Ariana beautifully took us through this, ask the person in crisis to define the terms used for specific substances, for symptoms they're experiencing. This helps build rapport, decreases misunderstanding, and helps us to develop a person-centered safety plan. We talked a little bit about how mobile crisis teams are really encouraged to learn and use the SBIRT approach and brief negotiated interview method. And this can help them in the response to people who have substance use disorders, as well as people who are having mental health symptoms, so that we can work both and help get them the right size care, reducing risk, infections, behavioral health symptoms and issues, and leading to positive support in social functioning. We talked about how important it is to operate from the stage of change. Again, my colleagues talked about people with lived experience are so important on these teams because they can meet people where they're at. So yes, it is extremely difficult or frustrating or hopeful when you're at these different places. And that adds credibility to the encounter that is really important for people feeling heard, supported, and cared about. And then Josh did amazing in talking about opioid overdoses, the use of naloxone, how important it is to get training, as each mobile crisis team has to have somebody trained when they go out, but that there are all kinds of resources different counties may have. You might have an EMT that can go out on it. You can do sort of parallel dispatch so that not everything has to go straight to 911. But it is critical that we understand safe administering of naloxone. We really look to see what partnerships we can have in our communities so we're responding with the right level of care, and that people begin to trust our mobile crisis system and know that this is something that's going to help me and not something that I'm going to have to face interactions with law enforcement or something that's going to deter me from getting the care I need. After these slides, there are lots of resource materials, examples of screening tools, additional resources. There's even some really amazing case studies and some discussion questions that you can use with your teams to just practice. You know, if we were to go through this, what would it look like? How would we manage? Here's some questions. So we really wanted to try to provide you with robust materials. And I really want to thank our partners to EHCS. I want to thank CARS. Because they've done an amazing job putting together a really information-packed training for you today. So with that, I know we have 10 minutes left, and we want to be able to offer an opportunity for some questions. I don't know if any of my colleagues have been able to monitor the chat or the Q&A to bring up anything.
So an anonymous participant asked if we would cover or discuss the consent and ROI in integrated text for COD.
Okay, so I'm thinking what they're asking, if this is what and somebody else can jump into, is if we want to be able to collaborate with other individuals. So if you've got somebody that you're working with and they have a behavioral health provider, they have a medical provider, we want to get them a release of information. Now, remember, in the bin, there is the opportunity to be able to engage. So we want to make sure we're in alignment with the bin in what we're covered by the bin to be able to do. And then outside of that, getting those releases of information signed so that we can provide ongoing collaboration and treatment if in our follow-ups we're learning something that could be very helpful to that process. And as far as consent needed for Narcan with minors, so one of the things that we did review when we reviewed statute is in order for them to get any kind of replacement narcotic abuse treatment, it does have to have parent or guardian consent. Oh, you know what, Josh, somebody asked a question earlier. I was wondering if you, because of your experience as an EMT, how do you protect yourself from fentanyl exposure in the field?
Yeah, that's a great question. To be mindful, to be aware of that the scenes we're rolling up on, maybe there's some active use, and the safety of the responder is very important, and the safety of the scene is also important. And if there is, if you are responding to a substance-related crises, to be mindful of that. And some people wear gloves, but also carrying Narcan on you, having your partner carry Narcan, that sort of thing. And if you are able to organize the response in an open area where there's lots of air, fresh air coming in, being in an enclosed space for too long, sometimes those particulates, could be exchanged, but really it's for coming into direct contact with the substance or powder is, I don't imagine mobile crisis responders are going to be getting touchy-feely, we're up close and personal checking vitals. That's, so if you keep your distance, and the risk is relatively low. Now, if you're kind of poking around, and like if you were a medic and you're taking vitals, or you're needing to remove clothing to get, an airway established, there's some greater risk, but that is not for this case in mobile crisis. So just some carry Narcan with you just in case. And it's always best to be checked. If you're feeling something after responding and you're just not feeling right, it's better to be safe, and go and get checked yourself. And so, but in terms of responding to the scene and knowing that there's substances there, that's your safety call, and you have to make that decision, and just being transparent, saying, I don't know what's in there, and trying organizing an alternative response, or at least somewhere where there's fresh air. So those are my recommendations.
Good. I wanted to also clarify something. Jacob had presented the comment about parent or guardian consent is not needed during an emergency if you need to administer Narcan, correct?
Yes. Thank you, Jennifer.
Right.
It's about speak on that. I did put in the link in the chat, a link that takes you to the naloxone distribution project frequently asked questions document that is put out by the Department of Healthcare Services here in California. And in California, Jacob is correct. There is no statute requiring minors to obtain parental or guardian consent prior to receiving naloxone. And additionally, there's a civil code that indicates, it can be distributed to a family member, friend, or other person in a position to assist for a person at risk or suspected opioid-related overdose, which would be a crisis, as Jacob was saying. So just wanted to clarify that, and the link is in the chat to that PDF.
Great. And for the parental consent guardian, the replacement narcotic abuse treatment would be things like methadone or buprenorphine products, things like that. So that it's more of the non-emergent type of, replacement treatment that is what they're really referring to with that consent piece of it. So I wanted to make sure we clarified that. I think we're getting close to the end. I don't know if anybody has questions that were not answered. We do apologize. I think there's lots of people who are saying we could have had more materials up. Right, like we were talking about this when we were putting this together. I mean, we asked for 2 hours. Originally, it was an hour and a half because we saw how much material we were trying to get in, and we do recognize there's so much more to continue learning about this. So we will be working with CARS to develop additional trainings. Office, I want to plug their office hours too. So they have technical assistance office hours. Danielle can talk about that, where if there are other topics that didn't get addressed, that there may be a place where they can, bring that up as well. Like we had somebody mention the topic of post-acute withdrawals could really be helpful to learn more about as well. So we really encourage you to continue using that resource. And I think they've got some really amazing participation in those meetings. So please, by all means, continue asking questions. Let us know what's happening in your counties and in your communities so that we can really provide training that is going to be, accurate to your experiences. That's really important for all of us, and especially for DHCS. Sometimes field-based policies can be a challenge with getting people referrals to care. So I do think at the county level, finding out what are those policies. I know where I live, oftentimes it was labs, same-day labs. And if they couldn't get same-day labs, by the time the individual got to the place where they could do the labs, the bed was gone. Mm-hmm. So being able to figure out what are the policies in our communities where we may have to do some advocacy work so that we can better streamline services, or if it's a policy where people want treatment to happen sequentially, being able to advocate if people have been down that path before, where we want to try something different, or being able to identify resources where they can do both.
That's a really great point, Jennifer. Knowing policies, and also, if there are MOUs in place, partnerships, and all that care coordination that happens when you're in the field. I think it's not often recognized how much care coordination happens when you're directly out in the field, and how you're trying to manage the crisis as well as the linkage. And that can be difficult. So relying on your teams, back in the office, or whoever's sitting at dispatch or triage for that support is also really helpful when you're out in the field. Any other questions or wonders or thoughts, comments?
This might be one too, Josh, that you want to, with fentanyl in or on nearly every drug imaginable, how does this increase use of naloxone even when known drug of choice is laced without knowledge of the person in crisis? Do you have a thought on that one, Josh?
So from that question, what I'm understanding is, how do we know? And because fentanyl is being laced into everything, how do we know if it's this or that? That's maybe what's being asked here. And so, like I said, it's really important to err on the side of caution. It's administering naloxone. Naloxone is a very effective drug, but it's not necessarily harmful to the body. And in the in-person presentations and trainings that I've done for administering Narcan, I administer it to myself to show people that even if you do not have, it is best to err on that side of caution, because I just get a little, but it is best to err on that side of caution. And even if the person's substance of choice is, let's say, meth or other things, you're not going to do harm by administering that and still looking for those symptoms and looking for that overdose situation. So I'm hoping that spoke to that. I'm hoping that answered it, but if not, please, David Turner, let me know.
Anything else, Danielle?
Again, please feel free to email us. You can go to our website for any sort of TA request and to register for office hours, which are the first Thursday of every month. Thank you so much for being here with us today. And thank you to our wonderful presenters, Ariana for sharing your story, Jennifer and Joshua for sharing your expertise and experience, as well as Ariana. And I hope you all have a great rest of your day.